if a kiddo is mouth breathing, their tongue is not getting to the roof of the mouth. And when that tongue doesn't hit the roof of the mouth, that's our vagus nerve, right? That's that fight, flight, freeze. And so as soon as that triggers, then we become an even bigger open mouth breather. And so we might see a kid that they might drool, they might not drool. But if they're starting with open mouth breathing, their nervous system and their neuroinflammation, it's going to skyrocket. I always say you can supplement and medicate. We can do that all day long. We are throwing money in a paper shredder if they are mouth breathing, because mouth breathing is going, if we've got that tongue up and we've got them into a rest and digest state, boom, the dominoes hit. Their sleep improves.
Welcome to Demystifying PANS and PANDAS, the podcast where we uncover the mysteries, breakthroughs, and hope behind these life-altering conditions. I'm Dr. Nancy O'Hara, a board-certified pediatrician, educator, and advocate with over 3 decades of experience helping children and families navigate the challenges of neurodevelopmental and neuropsychiatric conditions, especially PANS and PANDAS. These disorders can feel overwhelming, but here we'll break down the science, explore transformative treatments, and share stories of resilience and recovery. If you've ever wondered what's possible for your child or how to find answers, this is the place to start. Let's dive in. Hi, everybody. It's Dr. Nancy O'Hara, and welcome back to Demystifying PANS PANDAS. And I'm really excited to welcome our guest today, Bri Kurcsak, who is an amazing occupational therapist in North Carolina. And I have learned so much about the role of sleep and airway and feeding in PANS and PANDAS. And I really wanted Bri to come on and talk about that today. Bri earned her Master's of Science in Occupational Therapy from Belmont University in Nashville. And she's had over 19 years of clinical experience as an occupational therapist with advanced training in infant, toddler, child feeding, pediatric, pelvic floor, sensory motor development, and wellness related to nutrition, healthy sleeping habits. She's the founder and lead clinician of Flourish Carolina, a pediatric private practice in Charlotte, where she provides integrative and whole child care to children and families. And she's a national lecturer for MAPS, TACA, and deeply committed to interdisciplinary education and community outreach. She served as adjunct faculty and continues to lecture at colleges, universities across the country, contributing to the education development of future occupational therapists. Bri, it is so wonderful to have you here. And I've learned so much from you and about how what you do affects the kids I take care of and what I do. So thanks for being here.
Thank you for having me. It's an honor.
Well, I really, as I said, you specialize in airway, feeding, and sleep. So why are those systems so critical to kids with PANS and PANDAS? And why are they often looked, even by me? I overlooked them 10 years ago.
Yeah. Well, I mean, 10 years ago, we weren't talking about it. It was just, we assumed kids, they just eat and they just sleep and they just poop. And it wasn't something, in OT school, we didn't investigate this. We had a semester of feeding therapy. And it was like, there you go. You're out into the OT world and figure it out. And I really hit a point where I was like, I had a college professor say to me, and God love her, she's been the driving force in the back of my mind, say, Bri, I just really worry you can't see the forest for the trees. And I'm like, but these small details that these kids are without verbal, skill, they're not telling us, they're showing us. These small little clues make the forest, they make the big picture. And I remember that moment, sitting in grad school saying, okay, I'm going to get through this program. It served me well, but there's so much more to this. And really just kind of went down an integrative path to say, these kids aren't eating, sleeping, and pooping. And 19 years ago, coming out of school, I was doing shoe tying and digging beads out of putty in your traditional OT. And it was like, wait a minute. I just kept seeing kids get sicker and sicker and these layers and layers of uncovering. And I just started kind of digging backwards and really got into feeding, knowing, all right, it's such a source of contention with families, right? Picky eating. I hate the term. I don't believe in it. There's always a root cause to it. And it's like, it's rarely just picky eating. There's usually so much more that goes into it. And so when kiddos are getting this sensory based path of, feeding without looking at how is their tongue moving? How are they
Yeah.
breathing? How are they sleeping? Are they pooping? How the heck are we doing feeding therapy if no one's investigating their entire airway? What is happening with their bowel habits? We're just over here like, Johnny, I just really need you to eat your fruits and vegetables. And
Yeah.
so I feel like you can't look at one without the other. It is a
Yeah.
head to toe approach. And when a kiddo is not doing one well, they're likely not doing any of
Yeah.
those categories well at all.
And I so appreciate, the integrative approach, the functional medicine, the root
Yep.
cause approach. It's all what we talk about on this podcast and
Yep.
as you know, in my practice. And
Oh yeah.
it's so amazing. We don't have as many people like you around me. There are
Not yet.
some.
Yep. Yep.
But it's so amazing, to be able to talk to an occupational therapist who's not just giving the M&M
Yeah.
to get the behavior
Yep.
that you want. And
Yep.
the other thing that comes to mind as you speak is all the ways that what you do and what you're talking about affects the vagal nerve and
Yep.
is affected by the vagal nerve.
Yep.
And so much in our kids with PANS pandas, it's fight, flight, freeze behavior.
Yeah.
And what I've come to learn is how much what you do really affects that
Yeah.
and how these kids can get better.
I love to say, food refusal, sleep refusal, poop refusal, whatever it is, it's not defiance. It's not behavior. It's protection. Their
Yeah.
body is so inflamed. They are just trying to make it through the next meal. They are just trying to make it through the next night of sleep. They're not giving us a hard time. They're having a hard time. And their
Yeah.
body, speaking of the vagus nerve, there's these kiddos are living in fight, flight, freeze. They are at a level where they can't come out of it. And so, the packaging of the box or the container of the food that changed, or that one soft, smushy blueberry versus their hard, firm, crunchy blueberries that they like. That's enough to send their nervous system. It's already at its peak and it can't come down and regulate. And now, okay, I just ate the yucky blueberry. Blueberries are gone. They're done. And it's like,
Yeah.
dang it, we lost a food.
Yeah. Yeah, so important. And like you said, these feeding challenges are not behavioral.
No.
So explain a little bit more how the neuroinflammation, the nervous system threat responses, how that impacts the eating, the appetite, the oral motor skills.
Yeah. So it's interesting because, I started working with kiddos with PANS and PANDAS years ago, 7 years ago. And it was like, my first couple of cases, it was, oh, they had this sudden onset of picky eating. And I'm like, okay, wait. So they weren't the toddler that at 2 or 3 just stopped eating. It was like, no, they're 5 and they woke up and they stopped eating. And I'm like, okay, wait a minute. So it really took me down a deep dive of like, this is so fascinating. And, there's so many more layers to this. And uh, really digging into it. And as I've, been practicing more and seeing kids are flying in from all over the country to see me. I'm getting, emails and phone calls. I heard you at Taka or heard you at MAPS, help my child or help these, patients of mine. And I'm finding that these kiddos, the flags from an airway standpoint have been there. And, as I go through history and intake, it's like, okay, did they have breast or bottle feeding dysfunction? Oh, yeah, they would never take a bottle. They just breastfed for the year and everything was fine. And then, they went on to solids and we did baby led weaning and then they hit 2 and they just, they were a picky 2-year-old. And I'm like, okay, another red flag. And it's like, it's just the story kind of keeps progressing. And so when I'm evaluating a kiddo, I'm looking back at their whole history. I know it's sometimes hard for parents, especially when, we're in the stress point of a new onset. Maybe they don't even have the diagnosis yet, but I'm going all the way back to the beginning to say, let's
Yeah.
problem solve structurally. Let's see, do we have red flags that maybe they were getting the job done, breast and bottle feeding, but they weren't doing it with good skill? And that tells me a lot of what's happening with the tongue. Does the tongue know how to move correctly? Because that's a cranial nerve. So if we've got neuroinflammation in the brain and we've got feeding challenges, there's something not mixing together. So yes, we can have the sudden onset of food refusal and, sleep refusal and things, but I'm going all the way back to the intake of day one. What did their
Yep.
sleep look like as an infant? What was their breathing pattern like? Oh, oh, they snore. That's a Smith family gene. I'm like, common, not normal. And so we're looking at if that tongue does not have good mobility for eating and drinking, that likely tells me that it's not suctioned up into the roof of the mouth, which is our vagus nerve.
Mm,
There's our rest and digest. Well, that then directly
yeah.
plays into our body getting into parasympathetic and sympathetic state, which is that up and down of our nervous system. Well, that's going to impact our sleep. And then once our sleep
Yep.
is impacted, that impacts our hormones, that impacts our digestion, our vitamin and mineral absorption, then playing into the leaky gut. It's just the dominoes just keep falling. So it's like
Yep.
we have to look all the way back. And I always say, I start with an oral exam. I'll have kiddos that often they can walk in my office. I take one look at their facial structure and I'm like, all right, I know where we're going. It's already that obvious.
Yeah. Yeah. And, for me, I always focus on the three-pronged approach,
Yep.
antimicrobials, immune system, support,
Yep.
symptom support. But I never previously, until really the last 5 years or so, focused on things like oral
Yeah.
posture and mouth breathing and the tongue function you're talking about. And those are so important. And like you said, that kid that walks in with their mouth open, I may have previously thought, well, their sinuses are all blocked up, or they look, a little bit like they may have a low IQ.
Right.
None of that may be true.
No.
It has more to do with their oral posture, their mouth breathing. So talk
Yeah.
about those airway mechanics a little bit more and how it
Yeah.
influences these kids.
I say that mouth breathing is a danger sign for anyone. Anyone, you don't have to have pans and pandas. Mouth breathing is a danger sign. And it's normalized, right? I was just on a field trip yesterday with my fourth grader, and I couldn't shut it off. I was like, Bri, stop. I mean, I was analyzing and evaluating all of these kids, just their oral posture. And I'm like, no wonder this little guy, he's just so slumped over. He can't even hold his body upright because everything, it's like he has puppet string, marionette strings just pulling down on his entire
Yeah.
facial structure. And so if a kiddo is mouth breathing, their tongue is not getting to the roof of the mouth. And when that
Yeah.
tongue doesn't hit the roof of the mouth, that's not that's our vagus nerve, right? That's that fight, flight, freeze. And
Yeah.
so as soon as that triggers, then we become an even bigger open mouth breather. And so we might see a kid that they might drool, they might not drool, but if they're starting with open mouth breathing, their nervous system and their neural inflammation, it's going to skyrocket. I always say we can't you can supplement and medicate. We can do that all day long. We are throwing money in a paper shredder if they are mouth breathing. Because
Yeah.
mouth breathing is going, if we've got that tongue up and we've got them into a rest and digest state, boom, the dominoes hit. Their sleep
Yeah.
improves. Their gut can do its job. So kids who, if they're mouth breathing and parents will say like, no, they're getting 10 hours of sleep or 12 hours of sleep. No, but how restful is their sleep?
Right.
We know that mouth breathers, it is a proven fact that their IQ scores are lower. We are
Yeah.
depriving them when that oxygen deprivation is happening. That's absolutely impacting. We know you don't sleep well for a night. You wake up, you're like, oh my gosh, I'm foggy headed, I'm exhausted. And now we've got these kiddos that have all of this other inflammation in their body. The mouth breathing is like, I always say it's the red carpet into in head to toe inflammation because if we're not nasal breathing, we don't filter out, we blow our nose, right? We blow out germs, dust,
Yeah.
bacteria. We're mouth breathing, all of that in the air gets a straight red carpet invite, boom, hits the tonsils. There's our lymphatic system, messes with the gut. It impacts all of it.
Right. And so much to unpack there. I mean, first of all, it's not just PANS pandas. When
Nope.
you talk about snoring and restless sleep, I've had kids come to me for assessment for stimulant medications for
Oh,
ADHD.
yeah.
And if you do a history that involves, sleep and the mouth breathing, and you fix the sleep apnea, you
Yep.
remove the tonsils and adenoids, not for strep, but for obstructive sleep apnea,
Right.
all of a sudden the kid has no ADD symptoms.
Right. Well, and to that point, I'll get kiddos that the parents have done that. They've done the tonsils and adenoids, and no one looked at the tongue. No one looked to
Yeah.
see, okay, I always say in, airway dentistry is huge. I work very closely with a phenomenal airway dentist who orthodontist who's really looking at opening the entire airway. 20
Yeah.
years ago, we just took teeth out of a kid because we said, oh, yeah, they don't fit. Your jaw's too small. You're too narrow, instead of opening them up. And we've got parents, I see parents all the time, highly medicated on, ADHD meds. A lot of them, they'll be on meds for mental health issues, or, oh, they have this or they have that. And I'm like, the dark circles under their eyes. And no, they sleep 12 hours. I have to wake them in the morning. They are just dead asleep. I'm like, their body is not getting quality. I don't care about the
Yeah.
quantity of sleep they're getting. I want to know their quality. And it's
Right.
hard because as kids, if they're not interrupting your sleep as the parent, you don't know. You're like, no, they're in their room. They're fine. Never
Yeah.
realizing how disruptive their sleep can be from the start.
Right. And we're not talking about expensive stuff. I
Yep.
mean, a parent can set up their iPhone and do a video of their child at night to show that they're a very restless sleeper. Or every time they get into that deep REM, restful, rejuvenative sleep, they wake up because of the obstructive sleep
Oh,
apnea
yeah.
or the posture of their tongue or whatever. And, it's not just about the cranial nerve inflammation, it's also about that the immune system rejuvenates during
Yep.
sleep. And
You're
if
right.
you're not getting to that deep REM sleep, your immune system is not going to recover
No.
and refresh and restore.
I say to
So,
parents in those cases, their body is just they're training for a marathon and they run the marathon every night. They're not getting
yeah,
into a place of can't their body can't rest if they're not breathing. As much as we don't love, Apple Watches and Whoops and, all the devices for the EMF exposure, that is a cheap way for parents, but most people have access within family. I'm like, every once in a while I'll get a parent that's like, no, they don't have a sleep issue. And I'm like, but I need you to prove it. We have to
right.
prove it. And I always like to say, okay, you took a family vacation, you shared a hotel room. What happened? Oh, they tossed, they turned, they snored, they were kicking, the siblings
Yeah,
said they're awful. And I'm like, all right, go share a bed with them for a night. Or, if you're happening, holidays are great. I love the post-holiday visits because people come up and they're like, you were right. They don't sleep. And I'm like, I know, I told you. But, throw an Apple Watch on. Now the detection, and like I said, yeah, you're getting some EMF exposure and the negatives for it. But the positives, it can be free data if you have access to that watch. And it's amazing. I tell parents, I'm like, I need a screenshot. I need a screenshot. And I want you to do it over 2 weeks and just do like every other night. Don't just do tonight. Don't do 2 nights in a row. Let's bounce around because, maybe they have sports. Maybe they had a busier day, a less busy day. I really want to see over a couple weeks what does the quality of their sleep look like, and that often is enough of proof. It's like it takes parents usually 2 nights and they're like, oh my god,
exactly.
you were right. I'm like, I know, but it goes, I think in my opinion, sleep, picky eating and feeding challenges, it's obvious. It's all day long. Parents are so frustrated. But sleep issues go so undetected because it's kind of like bowel issues. Once we stop wiping our kiddo's bum, we don't know what their poops look like
Right.
unless they tell us or we're actively investigating. So the sleep piece is crucial and so
Yeah.
overlooked all the
Yeah.
time.
And talk a little bit about then, so you find this, what are the things you talk to families about doing, or what are the things you do to try to correct the issues?
Yeah. So it's hard because a lot of times I look like, this magician. I just solved all of these problems in a 75-minute evaluation. And I'm like, okay, but buckle up with me because we've got months and years
Yeah.
sometimes of undoing. So sometimes parents get very excited and we have answers and we have a plan. And I tell them, now you got to buckle up with me. This can be,
Yeah.
we're going to do it the least expensive, the most efficient. I am not a therapist. My wait list is way too long. I don't pull kids in, for weekly therapy and just tap, lick, taste, food, sensory based. No, we're getting to the root. But from a sleep standpoint, if I detect, sleep disordered breathing or apneas actually show up and parents are like, I want to further, I want to sleep, I want an actual sleep study. Great. They can go to sleep medicine. They can go to their PCP. We've got, providers across the country that will ship kits out of state lines and you can do a home study. But I always say if you have enough check marks that we know you're restless, you're grinding, you're sweating, you are actually snoring, you're drooling on the pillow, nightly nosebleeds. If we've got all these signs, you can spend the money to get quote confirmation, or we can assume that you're checking enough boxes of sleep disorder breathing. So I'm right away looking then at the oral cavity. Why isn't the child sleeping? Do they know how to breathe through their nose? If they've been a chronic mouth breather, they
Right.
may not even know in the daytime. If they're watching a little show, or I always say riding in the car, if they're just in the back, tongue down. First, we're going to work on some training because it's pretty amazing for kiddos that, can follow commands, and parents that, can instruct them at home. I'm like, teach them to make a bubble, get that tongue, tickle the roof of your mouth, close your teeth, close your lips, and just breathe. Just breathe like you're smelling the flowers. It doesn't have to be this big obnoxious, but let's see, do they even know how to nasal breathe? If not, they're coming in for some therapy and we're going to teach them that. Second part is breathing is one aspect, but so is tongue mobility. If they can't get
Yeah.
that tongue moving, the amount of children that come into my office and I say, I want you to tickle your very back tooth with the tip of your tongue. They can't do it. They can't move that tongue back there. So if
Yeah.
they can't reach their back molar, they sure are not chewing meat and fibrous vegetables that need to be chewed back there. So no wonder they're eating that, I call it the tan soft diet. Your waffles, your pancakes, your quesadillas, your yogurt, it's carbs and dairy because that's all that they can eat using the teeth here.
Right.
So I'm looking big picture of we've got the sleep study, or we've got sleep disorder breathing checked off. I'm checking nasal breathing. I'm checking tongue mobility. And if they're of age, so in Charlotte, we've got a provider that 3.5 can do a full comprehensive airway scan. And what that's going to look at is, what does their sinus cavity look like? What do their adenoids
Mm.
look like? What does the growth and development of their upper jaw look like? Well, the upper jaw, I always say, is our garage. And if our tongue is a Suburban and it fits our face, but our garage is fitting a little Honda Accord, that tongue has nowhere to go. So if we can get them scanned and look at what is their airway and the dimensions of it, predictable future growth, they might benefit from palate expansion. And there's lots of,
Right.
forms and lots of ways, but we got to get their garage into a 2-car garage. We got to get that tongue so it can fit up there, because if it's constantly wiggling and it can't fit, why is it going to keep going up there? So after we've got the sleep study, we're going to probably get an airway exam. After we've got the airway exam and have a path there, I need to teach that tongue. It's a muscle just like any other muscle of our body. So I need to teach it where it lives. It lives in the garage. And we're doing that obviously with fun. We're not just taking a toddler or a big kid and just, it's fun, it's silly, we make funny faces, we use food to do it. But I won't touch a kiddo with any sensory based, feeding therapy. That is the absolute end. I'm looking at breathing airway first. So usually those steps for parents: sleep study, airway orthodontist, looking big picture, getting that tongue. If they need ENT and they need surgery, every case is different. A lot of, moms groups and things. Oh, we did this and we removed tonsils and adenoids. I'm like, check the tongue. No two kids, even within a family, a sibling set, are necessarily the same. So
Yeah.
we're hitting that hard. And, when kiddos, if they go into expansion and we're getting some orthodontic work done, we have to be mindful of our PANDAS kiddos, because that's messing with those cranial nerves. That can send kiddo
Right.
nervous systems in and of itself. So there's a lot of factors that we're looking at on what is right for this child right now, and what is
Right.
going to be our best bet, long term, to get us our eventual goals of nasal breathing, quality sleep, etc.
Right. And again, so much to unpack there. I mean, I love
Yeah.
analogies, and that garage analogy
Yep.
is great. I never heard that before. And so many of our kids, you can just see it mentally, that that garage only has room for that mini,
Yep.
and you really have to work on that craniosacrally,
You do.
orthodontically,
Yep.
OT, all of that. And then the other thing I always remind practitioners about, whether you're doing a telehealth visit
Sure.
or an in-person visit, look at that tongue. Play games with the
Yeah.
kid. Ask their kid to put their tongue up to their nose
Yep.
and look at the sides. There's so much you can learn.
Yeah.
I mean, I learned it first from a acupuncturist,
Yeah.
how much you can learn from the tongue, the scalloping
Yes.
with adrenal stress,
Yep.
the coloring, when it's white with yeast overgrowth, the
Yep.
strawberry tongue with pandas, but so much, the tongue ties,
Yeah. Oh,
not
yeah.
just the tongue, but all
Yep.
the other ties
Yep.
with MTHFR and other
Yeah.
things. I mean, there are so many things you can learn.
Yes.
You should be looking at that.
And even, as a physician that feels, is hearing this and they're like, oh my gosh, I need a course in this. We'll get you trained. But
Yeah.
ask the child, mom's got snacks in her bag at your appointments. Ask the child to eat. Just watch them eat. And you don't have to be a feeding professional to watch a kid eat. If that's the kid that you're like, okay, what the heck is happening here? We've got to address that.
Yeah.
If they're the messy eater, if they're just smacking
Yeah.
their lips all around. These are basic things that we, as outsiders, look at a restaurant and judge like, oh my gosh, that kid's so, they're making a mess or whatever it is. Those are the basic, obvious things. And yes, there are kids that don't have as obvious of symptoms, but, ask, just like you said, ask them to perform some things. I can make a quick little checklist for providers to say, look at these 5 or 10 things. And if you see this, get them to an OT that's going to look,
Yeah.
comprehensively and do the big picture evaluation on them because that is imperative for their healing. Imperative.
Yeah, absolutely. Okay, we've talked about sleep. Let's talk a little bit more about food and eating. There are some kids with PANS pandas that have a fear of choking or vomiting or
Yep.
contamination.
Yep.
There are others that present more with gagging
Yeah.
and pocketing
Yep.
food and the fatigue with chewing and all of that. Talk a little
Yep.
bit more about those patterns.
So I always say assume function or dysfunction before behavior always. We know that those are your baseline symptoms, right? My own son woke with his journey with pandas and one day I was, making dinner and he said, "I don't eat broccoli cooked longer than 15 minutes." And I nearly dropped the pan. I was like, there it is. There's his check mark right there, right in front of my eyes. And I was like, what do you mean you don't eat broccoli cooked longer than 15 minutes? He's like, I don't. It turns brown or whatever he had said. And, I look at these kiddos and I say, this is neurological overload. Their
Yeah.
body is having to pick what is survival. And the brain is making up to parents and providers and care teams these arbitrary rules like I don't eat broccoli cooked longer than 15 minutes, or I don't eat purple foods. I don't eat meat now all of a sudden. So we first have to look for these kiddos to say, okay, if we have the sudden onset of gagging, what is going on neurologically and within their nervous system? Because this is a non-PANS pandas kiddo or, any situation, you have a gagging episode, you had a trauma related to that food. So you're then going to look at, let's say you ate too big of a bite of a bagel and it didn't go down easily. You're now going to look at bagels. You might even look at English muffins. You might even look at a pizza crust. The brain starts playing tricks and it will say, oh, that's going to happen again. So not only do we have that side of maybe there was a trauma or there was a negative experience, grandma said you're not getting up from the Thanksgiving table till you clear your plate. And it's like, that created a stress point there. So we have to look at traumas, but we also have to look first before we look behaviorally, we have to look at oral function. So is if there's a gagging episode and a sudden onset of, food refusal and picky eating in pandas kiddos, okay, we've got to look at that. But did they actually have some red flags from a feeding standpoint prior that were just never picked up on?
Yeah.
And the majority of kids that I see, they had that going on prior, it exacerbated. And now
Hmm.
the symptoms around the eating, really rose to the surface. And because we're getting refusal and we're getting avoidance, it's like, yeah, no, they never had a feeding problem. And now they do. Obviously, that's even more of a marker of like, okay, we've got to get you to an integrative specialist. We got to see if this is, PANS pandas going on. But overall, it tells me if we're gagging, if we're refusing, if we're avoiding, there is something nervous system and neurological happening where the brain and the mouth, they're not working together. And
Yeah.
was it a minor episode that triggered something? Is it a large, is it neuroinflammation? What's happening in between? But first rule out, can they do it? And then if they physically and structurally, there's no tongue tie, they have the mobility, then we got to look at, is this trauma? Is this inflammation? Is it OCD? What's happening that is causing these, rules and stipulations, if you will, around this? It's neurological overload.
Right. And I think it's so important to ferret out all those different things.
Yeah.
The trauma piece. I mean, in my own personal history, I had to do a Heimlich on the side, on a counter side, choking on a vitamin C pill.
Yeah.
So
Yeah.
I still, to this day, I have that little twinge of fear every
Yeah.
time I go to swallow my pills.
Absolutely.
And so you got to know that in the child's history,
Yeah.
the OCD part of it. I mean, sometimes the only wanting to eat this is part of their OCD.
Yes.
It's a color
Yes.
thing, not a
Yep.
texture thing or
Yep.
whatever. And then, to all the other things we're talking about, sometimes it's a mouth thing. And so knowing those, each one of those can be important pieces, but knowing which one or ones it is
Yeah.
really helps the approach and the management.
Well, and that's why we have to look at all of the pieces and the big picture and know as a therapist to ask the right questions, because we're so often as OTs trained to come at the sensory aspect of it. Oh, it's sensory. And then if it's not a sensory issue, the way the food feels, it's a behavioral issue. And I'm like, no, we're missing these little, that's where I'm like, forest trees. She said it to me. No, these are the little clues that what's been going on, each little tree to create the whole forest that makes this big picture. We've got to be able to look at that and decipher that, because this is where traditional feeding therapy, I get kids, "Oh, we've been in OT for 3 years. Oh, we've been in OT for, what?" And I'm like, what have you been doing? What have you been doing? And a parent can't say to me what they've been doing. I'm like, you've been dropping them off or paying this copay. Like, no, you're involved. You're in these sessions. And if you can't be in, the nanny or the au pair or whoever's here, they're videotaping, they're taking notes. Like, this is a family involvement in looking big picture at these kiddos. And we've got to go back. I'm going to jog parents' memories to places that they're like, Bri, I don't remember. But sometimes the kids pipe up and like, well,
Right.
on da-da-da date, this happened. And I'm like, there it is. There
Yep.
it is. And that's then, that takes us down this path of treatment. It's like in any given day in clinic, I always say I'm 8 different versions of Bri, because I can't look at any 2 kids just like you. You're not taking
Yeah.
any 2 kids on their intake form and treating them the same. You're digging to ask more questions and say, there it is. That is
Yep.
that important piece of information that's going to guide us to this treatment path.
Right. And I think something else you said is so important. This isn't one 45-minute or hour session once a week
No,
that's going to solve all these problems.
no,
This is a whole child approach,
yeah,
but also a whole family approach. That
sure,
unless these things are reinforced and in some way, in a fun way, therapized, I
yeah.
don't even know if that's a word,
Look
but
at the word.
whatever, at
Yep,
home,
yep, yeah.
it's not going to work.
Right. Well, and specifically in PANDAS cases, if you've got, one kiddo that is creating unintentional stressors over eating and the family meals, it is impacting. I live it. I've lived it, in my own 4 walls of it's a family issue. It's a
Yeah.
friendship issue. It's the big picture, and it can create feeding issues or a kid who doesn't sleep. These
Yeah.
basic ADLs, these basic activities that we all engage in, eating, sleeping, and pooping, when they're not happening and it's disrupting the entire family.
Yeah.
So
Yeah.
it has to
Now,
be a
I heard you.
guiding.
Yeah, absolutely. And I heard you say these words a little bit earlier, and I want you to go into the tongue to toes
Yeah,
approach.
yeah,
Just talk about. I think you're saying it, but just
yeah.
explain that a little bit
Yeah,
more.
so it's kind of my, evaluation kind of pathway when I'm looking at a kid. Obviously, it's what I can see on the outside and what's so visible from a mouth standpoint, but I really start big picture of them. So I'm looking, in that multi-prong approach of, okay, what's happening in their balance and coordination? We have these kids that they're in OT, they're in PT, they're in speech, and it's like each therapist is doing their own thing, but nobody's coming back to put those pieces together to say, well, no wonder they have balance and coordination issues. It's because they're so severely restricted in their tongue with a tongue tie that their entire fascial system,
Yeah.
head to toe, is pulling them knock kneed, is pulling their pelvis into a tilt. Well, that's impacting their digestion and ability to poop and eliminate all the poop. So looking at a kid, from the top of their head all the way to the bottom of their feet. What are their primitive reflexes look like? Okay,
Yeah.
well, if we're just going and doing just primitive reflex therapy or just craniosacral therapy, okay, we're not looking at the entire picture. And sometimes kiddos I find are getting services with amazing providers, but they're dead ends. They're not getting better in that. It's because go back up the chain of the body, looking head, toes, tongue, toes, and see where is the root? What is stopping us? If we are in PT for body work, well, what's going on in the mouth? And
Yeah.
then vice versa, back down the other way. Why are we in feeding therapy if we are having pelvic floor issues or constipation issues and their body, their interoception and their awareness of eliminating and emptying the bowels, if that's not happening, you ain't making any progress in feeding therapy. So it
Yeah.
goes, you've got to be able to look literally head to toe at every single component and then be able to put it all together and say, okay, where do we start first to make the biggest impact? And that's what I
Yeah.
find missing as I teach and, educate other professionals. It's like phenomenal mindset, phenomenal intention on addressing this one issue, but then we just seesawed or whack-a-mole the others. And it's like, okay, wait, we got to step back and look at the big whack-a-mole pond and say, okay, we're going to get all these fires out all at the same time, or whichever one is creating the biggest wave.
Right. And going back to that fight, flight, freeze, again, it's so important to focus on all of this fascial and everything you're talking about. And I can just hear the parents that are listening or
Yeah.
watching saying, "Oh my God, I thought I just had to find a doctor or a naturopath or somebody to give my kid the right antimicrobial
Right.
or whatever. Now you're telling me I need to do
Yeah.
this whole other area."
Yeah.
So talk to families, why occupational therapy, feeding therapy, airway focused therapy, whatever should be part of their care team.
Yeah. I always say, I feel like we can't do this without one another
Yeah.
in getting to the true root and getting resolution, getting these kids healed. It takes so much. And it's so, parents that are listening, they're like, I know our bank accounts are drained, our
Yeah.
energy, mom and dad's nervous system is shot as well. It's a whole family issue. But I truly in my heart really am so lucky to have so many good practitioners that value the work that I do because, like I said, we've all been a new OT, we've all been new physicians, we've all been new in our jobs. And I think what keeps people learning and advancing in practice is going to bed at night saying like, man, that didn't work. Like I did this and it didn't work. We're practicing medicine. We're not experts. We're practicing every day and we've done it for 20 and 30 years. But looking at that big picture and saying, how can we work together? Because like you said, if you're addressing the gut and they're on supplements and meds and prescriptions and they're doing all of this and they're over your mouth breathing and they're not sleeping, we're not going to get them as far as they could get into a state of healing if we had those pieces together. So,
Right.
from a therapy standpoint, I'm really starting to see as I teach, I love when I latch on to that therapist as a student that I'm like, you get it. You're the me. You're looking at the forest, but you're also looking at the trees and you're looking at it together and saying, wait a minute, this doesn't add up. There is more to this. I want to learn about that other side of, collaboration. I think, and depending on the setting as an OT, sometimes we're very respected by physicians and sometimes we're like well, I don't know. I can't figure them out. The parents are complaining. Just get a referral to therapy. Those therapists will figure them out. It's like and sometimes we're the frontline defense in the parents are going to the pediatrician or their PCP and saying, hey, they're exhibiting X, Y, and Z. Help us. And physicians like, oh, it's behavioral. Oh, just go to some OT. That's what really drew me into this path and, working my way into the MedMap scene of like, this is a physician organization. But I'm like, we belong. We need in to
Yeah.
work together to get these outcomes. And we've shared kiddos, we have good results. We know that it's a big picture. And I think if we as therapists can help these kiddos function and regulate and live, that's what OT, our job is helping kids live, their
Right.
daily life. And we can be supportive to parents, then your work is going to work even more.
Right. Right. And it's not going to work as well without it either.
Yeah.
But I'm just thinking as you're talking, sitting here as a parent, and I'm like, my OT doesn't do that.
Yeah.
How does somebody, not everybody can come to you.
Sure.
How does
Right.
somebody know the right questions to ask to
Yeah.
figure out if their OT gets it the
Right.
way you do?
Right. Ask them flat out, like, hey, what's our plan? Parents ask OTs. I always say, ask your therapist, sit down with them, have a conversation. It doesn't even have to be with the child. Do a home program, a parent education visit of saying, what is our end goal? What is our plan? How long do we need to work? I love when a parent looks at me and says, how long do you need from me to work on this? And I can give them an estimate and say, we're going
Yeah.
to do 4 or 5 sessions. We're going to do this. And if we're not seeing results here, we're changing directions. I am not taking your time, money, and energy to just bring your child in weekly and spin wheels. Well, I need results. And so when I
Yeah.
give the parent, I say, here's your homework, go home and do these 3 things. And I get a text message 10 days later, a week later, my gosh, like I just saw XYZ. I'm like, we are on it. We're on the right path. So I am working on a project to maybe by the time this is published, it will be announced, but working on a project to help therapists look at this big picture mindset and see, okay, we learn all these wonderful things in school and in grad school. We take all of these amazing continuing ed courses, but I've yet to find one that's putting the dots together to look big picture. And
Yeah.
so it's coming. It's coming from an OT standpoint. But I
Yeah.
think if parents can ask their OTs, it's okay. I think we need to be self-reflective as all medical providers to know what are we really good at? Be really good at that. And if we can really sit and look at what our focus area is, I'll pull other OTs in who are really, they might be body workers. They might do primitive reflex work. They might be don't ask me to do anything vision related. I'm like, I didn't even remember vision stuff in grad school. So parents talk to your therapist and see, if you're not feeling heard, don't throw the baby out with the bathwater. Don't throw OT out as a no go. It might just be that provider's specialty is in an area that served its purpose then, and we just need to get another opinion. So
Right.
asking them, hey, what is your specialty? If you're a sensory based feeding therapist, get me in with somebody who can look at the airway, look at the oral motor skills, who can look at the mouth. And then do we need to pull somebody in that's pelvic floor trained? I just so happen to love being a nerd and learning, and constantly I'm like looking at all the pieces to it and put it all together. And I'm hoping that OT as an allied health profession is going to move into that direction because we need to. We need to be
Yeah.
looking bigger picture from a pediatric standpoint with our kids just being sicker. So have conversations, parents. If you're listening, have conversations with your therapist. And it's okay to say, can we pull or do we need to pull someone else in that specializes in this area? That does not make that therapist any less than at all.
Right. Right. And if they bulk at that, that tells you something too.
Yep.
And I think, yeah.
Yeah.
And I think as practitioners, we also have to remember to know what we know, but also know what we don't know. None of us can know everything.
Yeah.
None of us can be a specialist in
Nope.
everything.
Right.
And being honest about that with ourselves and with our families is really important.
Yes. Yeah.
Your child really needs chelation, but I'm not the person to do that with
Right.
you.
Right.
But if your child has a tick-borne disease, I'm
Yeah.
all over it,
Yeah.
whatever it may be. The same way with the pelvic floor, the
Yeah.
sleep, the eating, whatever it may be. Figure out your child and find the people to bring in
Right.
that can help your child master those things.
In this, pediatric population and PANS, PANDAS, and autism, and in all everything, it is such a team effort, and it's okay to, do a therapy or an intervention and pause it if you're being fed, that you're feeling led to another path. That doesn't
Yeah.
mean that intervention didn't work or isn't going to work. It may have just been the wrong time. And
Right.
I think
Exactly.
we as providers, the best providers that get outcomes are ones who listen to the parents. The parents are often coming in with, my kid is doing this, this, and this. We'll get parents that come in and they're like, I'm so overwhelmed and I feel like a bad mom. I had no idea they weren't sleeping. I'm like, you're not a sleep professional. You should be
Yeah.
asleep too because your nervous system needs regulated. Giving parents, homework that's effective. I need you to go home and track their sleep. I need you to go home, Johnny, and you and mom are going to have this deal, and you don't have to tell sister and you don't have to tell dad, but here's the Bristol stool scale. And I need you to come home from school every day and say, I pooped after math and it looked like number 4. Great. Like, we've got to start getting data and teaching parents to be the investigators, because they're the ones bringing information back. In my hour visits, I'm only seeing what's in front of me. I need their
Right.
support outside of it. And parents want to figure these things out. They're tired, they're exhausted, they want the support. If we arm them with the tools to be mini, I always say, like, you're turning into a mini little OT. Or, I'll love a parent, they'll text me and they're like, I'm on a plane and I see all these mouth breathers. And I'm like, yes, I know, right? Or it's like, at the family dinner, we're all talking about everybody's bowel movements. I'm like, great, because everybody poops. And it's teaching parents to lean into their intuition and be the investigator. I'm going to solve it for them. We're going to get results, but we've got to have a big team.
Yeah. And I also think it's important, something you said, to know when to do the therapy. For example, a parent will say to me, oh, I did that 5 years ago and it didn't work. And I will say back, well, your child wasn't prepared at that time.
Right.
They were still very constipated
Sure.
or they weren't sleeping and
Right.
it wasn't going to work then.
Yeah.
Let's retry it now.
Yep.
Or, you know what? Yes, you did it then, but you did it with this professional
Sure.
who wasn't really as well trained as
Right.
who I'm sending you to now.
Right.
And it may be a totally different experience. So
Right.
being open
Yeah.
to reopening those doors
Sure.
that you may have thought were closed before, I think
Yeah.
that's
Well,
important
I mean,
too.
you deal with that as a physician too, right? Oh, we've
Yeah.
seen so and so, or, we've done all of these things. What are you going to be able to do different? And it's like, I tell everybody, I'm not quarterbacking. I'm not Monday morning quarterbacking what, went on Sunday's game. Like, we are all looking, and sometimes it takes just a fresh lens to look at a kiddo and say, oh, well, this, da 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 da, do all of these things. And it looks so easy. It's like, well, why didn't my therapist do this last year or the last 3 years? Well, they're looking with a different lens. And I think
Yeah.
if we can just get more therapists, specifically, my goal, in my new project is to really get OTs thinking big picture, but you've got to get the little trees. You got to get the little trees
Yeah.
and those details to make the forest, because so much of our training is forest and this is what you do. And it's like, no, this little section over here and this little section here, these are all little clues that are going to lead us to that big picture.
Yeah. Well, Bri, I know so many people are saying right now, oh, I wish I lived in Charlotte. I wish I could go see Bri. But if somebody can, or if a practitioner wants to reach
Yeah.
out to you, first, how do they find you?
Yes. So if you're nearby or you want to make a flight in or you want to hop in a car and come on down, I've seen kids literally all over the country travel in, and it's been awesome. So my private practice is Flourish Carolina. So on Instagram, you can find us Flourish Carolina OT. And then I am launching the Peds OT, which is a journey to my lifelong dream of just teaching. I love teaching other OTs and getting them to look big picture. So on Instagram, it's Bri.thepeds.ot. And if you're an OT that, you're like, whoa, how did she learn all this? And how is she putting these dots together? That's a way that I'm hoping to really branch out and teach other professionals, not just OTs, but how to look big picture and help support you guys in this path of healing kids.
But I can see that to be so helpful for practitioners,
Yeah. Sure.
just to learn what we don't know, because it's, not only do we not get more than a half an hour of nutrition in medical school,
Right.
we don't get any
Right.
OT or anything like
Right.
that. So
Right.
it's
Well,
great for everybody.
we're the allied health team, right? We're there to
Yeah.
support, but it's like if we, as physicians don't know what our specialties are and what we sometimes just get lumped into, like, oh yeah, those OTs, they'll do some sensory work and they'll teach shoe tying, or they might get a kid to eat, a new brand of French fries. There's so much more, and within our scope as an OT, like, we can do it. It's just
Yeah.
it's a new way of thinking, and I'm hoping that the way that medicine is going and the way that our children are just sick, that we can look and heal so many more. The eager beaver parents that as an infant, they bring me their kiddo that's struggling breast and bottle feeding, and they come back at 6 months because they want to make sure they're doing well on solids. And they come back at 18 months to make sure that their mouth is developing correctly. Those are the kids that they are getting a lifelong gift from their parents to they're the parents that are looking big picture, and they're making sure, they have so much information on the internet. I didn't have that as a new mom 11 years ago. Like, it wasn't what it is now. But it's like those are the parents that are saying, "Hey, I just want to make sure we're on a good path because I want to be preventative. I want to be proactive instead of being reactive." So it's
Yeah.
the tides are turning. I
Yeah.
think we're moving into a good place. I think it's going to be great.
Yeah. Yeah. I so agree. And with people like you out there teaching us,
Thank you.
absolutely will be.
Thank you.
So, any last words of experience, strength, or hope you want to leave our families or practitioners with?
I mean, for practitioners, find your crew, find your team. You can't do this alone as a physician trying to carry the weight and the stress of it all. Find a team, create a team, have people reach out to me and say, "Hey, I listened to this or I got your information. Where can I go?" I'm interconnected with all sorts of training and other providers across the country that, "Oh, I have an interest in tongue ties." Great. Take this course. You're going to learn so much about them and how to evaluate them properly. These, especially tongue ties, these are things that we don't want to just be, "Oh, I took a weekend course and now go ahead and go get your tongue tie release." No, like this is a big picture piece. But, if you're a provider, find your team, create a team and train up together, really become experts. And it doesn't have to be just locally. You can have people outside of your city limits.
Yeah.
And then as parents, like, lean into your intuition. We so often, as a parent of kiddos with challenges, like, we so often dismiss them or let other professionals dismiss us, and we shut that off. Don't shut that off. Push through. There are providers out there that believe you, that want to help you. Find us. Find me. If I'm not the provider that you need, I'll tell you who to see in the community
Yeah.
of a different discipline. So lean into that. Oh, there's so many of us spending day and night and hours trying to heal kids. And we want healing and we want families to exhale and not feel so stressed out. So we're out there. Find us, reach out. We want healing.
Yeah. Absolutely. And as a parent, like you said, trust your gut, trust your child's gut, check your child's gut,
Check your
check their
child's gut.
poop, you
That's
know?
yeah. Well, they're like, "You
And
want me to trust my that's not emptying that gut for 4 days at a time, and we're gonna trust that? No, no, we're gonna get there. We're gonna empty that gut, and then we're gonna trust it, for sure."
yeah. Yeah. Well, Bree, so much great information. And thank you so much for all your pearls of wisdom, your hard work. I'll so look forward to the course you're planning
That
and all the lectures, at Taka, at MedMaps, wherever. So
Thank
thanks so
you,
much for all you do.
and thank you. Thank you for having me and all that you're doing.
All right. We'll see you next time on Demystifying PANS Pandas. Thanks, everybody. That's it for today's episode of Demystifying PANS Pandas. I hope you're walking away with insights, tools, and hope to help you and your child on this journey. If you found today's conversation valuable, be sure to subscribe so you never miss an episode. Share this podcast with anyone who might need it. It could be the lifeline they're searching for. And if you have a moment, leaving a review helps us reach even more families who deserve answers. Also, for more information, training, and community, check out our website, drohara.com, and join our annual membership. And remember, every step forward, no matter how small, brings us closer to healing and understanding. Until next time, be present, be hopeful, and we look forward to seeing you next time on Demystifying PANS Pandas.